Chapter 7, the Pediatric Spirometry Procedure. So in Chapter 7, I'm going to run through how to conduct the procedure. Now, most of this will be done through practical demonstration, but it's also nice for you to have a little bit of theory on it as well to refer back to. So we're going to look at how to explain and demonstrate a test to a child, how to position the child, the number of blows you can do, the timing of the tests, all the test procedures involved, exhalation versus full flow volume graphs, tips on coaching the child to give you good results, and going through the common problems and how to correct those. We're going to look at data validation, test quality grading, how to support children that are compromised in some way, looking at blowing-induced bronchoconstriction, blowing-induced bronchodilation, and then another thing, a quick look at complications and how you can prevent those, and then looking at critical factors when conducting spirometry tests over time. So after studying this chapter, you should be able to explain and demonstrate a spirometric maneuver to allay a child's fears and to obtain a child's maximum cooperation. Ensure child positioning is correct throughout the test. Conduct a spirometry test on a designated child in the correct number of attempts with correct timing between the maneuvers. Give clear instructions, maintain visual contact, and provide encouragement to the child throughout the procedure to ensure accurate outcomes and in terms of good clinical practice. You're going to be able to recognize equipment and subject testing errors and coach the child to blow correctly. Conduct on-the-spot data validation checks prior to completing test procedures, and conduct bronchodilator responsiveness testing using the correct methods, timeframes, and medication. So let's look at how to conduct the test. So first of all, the child should be seated with feet touching the floor, but they may stand if they prefer. So if a child prefers to stand, he or she may, and the position should be noted in the report of the test itself. So if the child sits, they always sit, and if they stand, they always stand. So on repeat visits for spirometry, as I say, they always sit or they always stand. In either the seated or the standing position, the child should always stay upright. Their torso must be upright. They must keep their head slightly elevated, and they should not bend at the waist when doing the test itself. If you look in figure 7.1, this is a picture of a child who is sitting up straight and blowing into the spirometer with his head elevated, with his chin at a right angle to his body, and he's not bending over. But in figure 7.2, in both of those, you can see that these subjects are bending over. So they are not staying upright. So seated or standing, that is incorrect. They need to be staying upright when they do the test itself. Now, when it comes to explaining the test, I usually explain to the child that we're going to work on the test together. They can't do it without me, and I can't do it without them. So spirometry requires that cooperation between the child and the technician. The procedure must be fully explained to the child so that they understand what is required of them, why it's important to perform each maneuver, and do it as best as they can. It takes effort to do the test, and they may become tired, and that's to be expected. You can also tell them that you'll give them all the breaks that they need between blows to regather their breath and to get energy for the next blow again. The child will blow many times, so you need to explain to them before they start that they will blow at least 3 times and up to 8 or even more than 8 attempts to get the results that we actually need. But that if they need a rest, you would be glad to give them a rest. If the child becomes lightheaded or dizzy during the test, they are immediately to let you know, and you will stop the test and allow them time to recover. So when it comes to actually explaining the test itself, you tell them that you're going to actually physically close their nose when you're testing. They're going to take a deep breath until their lungs are full, full, full. They're going to put the spirometer into their mouth. And I'll get this and show you. So the nose is going to be closed. They're going to take a deep breath in until the lungs are completely full. They're going to put the spirometer into the mouth. And when they do that, they must close their teeth onto the mouthpiece. And usually it's indicated their teeth must not be in the front. The teeth must be over the mouthpiece like this. They must then seal their mouth around the mouthpiece, and then they're going to blast the air out as hard and fast as they can and keep on and on and on blowing until the lungs are completely empty. They then at the end, when the lungs are completely empty, they breathe in again all the way until the lungs are completely full. And you are going to encourage them throughout this procedure. So this will be repeated over and over again until you have at least 3 perfect blows. Once you've explained the test, you need to demonstrate the test. So when you demonstrate the correct technique, you need to do it exactly like you want the child to do it, which means that you have to do the whole maneuver exactly as I've just explained. So this is what you're going to do. You're going to show them how to close the nose, breathe into total lung capacity, seal the teeth and lips around the mouthpiece, and then blast the air out as fast and hard as possible until they're empty, and then breathe in again. So let me show you what to do. Okay. Okay, so you saw how I remained upright, my nose was closed, mouth was on, sealed, and that's the test. So you need to demonstrate it exactly like you want them to do it. So in all cases, a minimum of at least 3 blows needs to be performed and recorded, but blowing must continue until acceptability and repeatability criteria have been met. So we'll go through that in great detail in Chapter 8. There is usually an upper level of about 8 blows for adults, but in children we allow them to do a few more blows because not every blow is usually a full blow until they get the hang of it. Children may benefit from practicing but different phases of the maneuver before you actually put them onto the mouthpiece. But remember that you don't want their enthusiasm to wane over time, and so it's probably better that you practice on the actual spirometer on the software of the program. You can always delete those blows later on. You don't want the child to become fatigued in doing practice blows and perhaps even missing the best blow that they actually do by not recording it. So I would say that practice attempts are okay, but do it on the spirometry software itself. The technician needs to give the child sufficient time between the blows to rest, and this can be anything from around 30 seconds upwards, depending on the condition of the child and whether or not they have respiratory disease. So what we know is that full inspiration and constant blowing can cause either bronchoconstriction or bronchodilation. So it's important that if there is blowing-induced bronchodilation, that you keep blowing until the child is fully bronchodilated. And remember, you would then record that on the actual test result itself. So when you're explaining the test to the child, you need to explain what the test measures, how much air they need to blow out in one big breath, and how to blow the air out as fast as they can. So you're going to measure how much air, how fast they can blow it out in one breath. Children will often blow and then blow again and then blow again like this. And you don't want that. So you have to remember to explain that it's one big breath that you want from them. And that to do it, they've got to take their biggest possible breath in. So what you want to ensure that they do is that they breathe into total lung capacity before they start to blow. If they blow in a suboptimal breath, you're going to have an incorrect spirometry result. So look at the difference. This is not breathing into total lung capacity. Okay, but this is breathing into total lung capacity. You see the difference? Okay, so remember that that's a key issue. You need to explain also how many times they're going to do it. So remember to tell them they're going to do at least 3 identical blows. All right, so once you've explained and demonstrated the test and you've attached a new clean disposable mouthpiece like this, you've entered your child details onto the machine, you've either applied a nose clip if you have disposable nose clips, or the child holds the nose closed themselves. You position them away from your equipment and away from you, and they blow out into a place where the infection risk is less. The child at the beginning of the test should hold their breath just long enough to seal their lips, and this in the guidelines is suggested at equal to or less than about 2 seconds. So from that point of maximal inhalation to the point where they're going to start blowing should be less than 2 seconds. 1, 2, blow. Okay? They should not purse their lips as if blowing on a trumpet. So like I said, the lips mustn't be in front, and as they're blowing, they mustn't pull their lips off the mouthpiece. Okay, so this is one of the things they do. That's wrong. Okay, what they should do is teeth right over the mouthpiece. They need to make vigorous effort right from the start of the maneuver. So they can't start off slowly like this. Okay, it's got to be. Do you understand the difference? And children with obstructive impairments can take a very, very long time to blow all the air out of their lungs. So make sure that you give them as long as they need to empty the lungs completely. But mostly in young children, they should blow out between about 1 to 4 seconds, depending on the age of the child. You should encourage the child to keep blowing until there is absolutely no air left at all. And then the child could breathe in again as forcefully as possible to total lung capacity. Most spirometers will beep once the air is completely exhaled. And on a machine, it reads that the air has slowed to 0.025 liters per second, and then it actually stops the test procedure itself. So once you've done this procedure and you've got it right, after every blow, you need to give the child feedback. So you tell them what they did wrong on that blow and how to get it right. So as we said, let's talk about some tips on coaching the child. So what's really important is that the technician lets the child that they've got a role to play in achieving the quality results and that you're going to work together. You need to use incentive graphics if you can. So that's pictures that the child can look at on the screen. They love to blow out the candles or blow bricks out of a wall or whatever the incentive graphic is on the spirometer that you've got. Put that on for the children. They love it. Even the adults love it. Throughout the testing, the technician needs to be watching the child. Do not watch your machine. Watch the child itself, because if you're not watching the child, you're going to miss the fact that their teeth are not on the mouthpiece, or the teeth are in front, or the tongue is going down the tube. You're going to miss those things if you're not looking at the child themselves. So remember also that encouragement makes a big difference. Don't be afraid to raise your voice to encourage the child, particularly near the end of the maneuver. The child needs to keep blowing until there is absolutely no air coming out. Now let's just say a quick word on the forced vital capacity maneuver, which is just the expiratory portion, and doing the FVC and the FIVC, the forced inspiratory vital capacity. So the forced expiratory is just blowing out and stopping at that point, and the forced inspiratory capacity is the full flow volume graph where you blow all the way out and then you breathe all the way in again. Now, you don't get as much information from the inspiratory portion of the graph as you do from the expiratory portion. And there's always the thought of infection prevention when you're breathing in. But the latest guidelines use the inspiratory portion of the blow to check the quality of the data of the test. So it's very, very important that the child does do both the FVC and the FIVC, the inspiratory loop, as well. Because if the forced inspiratory vital capacity is much bigger than the forced vital capacity, the expiratory portion, we know that the child did not start that blow at total lung capacity. So that is one of the main reasons why we want to do a full flow volume loop, is to make sure that the amount of air that the child breathes out is equal to what the child breathes in. Okay, and that's really for measuring the quality of the tests. So there are many errors that children make on a regular basis when conducting spirometry tests. It's very important that the technicians are able to recognize these errors and correct the child's techniques to ensure that the data is valid. So let's have a look at some of these. The first one that can't be helped by the child, but that the technician has to be aware of, is blowing induced bronchoconstriction. So some patients, as they're blowing with effort like that, that can cause the airway to bronchoconstrict, to close a little bit. And in these children, the FEV1 will become lower with each subsequent blow. So this picture can be differentiated from poor effort, as the child will usually become symptomatic at the same time. They will become short of breath, they might cough a little bit, wheeze. You usually see them becoming a little bit distressed or a little bit tight, you can actually hear the wheeze when they do this. And what the guidelines say is that if the FEV1 from an acceptable test drops below 80% of the start value of the test, the procedure should be terminated in the interest of that child's safety. So the typical pattern seen in blowing-induced bronchoconstriction presents as the first FEV1 is often within normal limits, but the FEV1 then falls with each subsequent blow, and often in that case the FEV1 repeatability criteria are not met. Following the bronchodilator, the FEV1 may or may not return to the best baseline level, but you need to have a look at that. So we can look at figure 7.3 as an example of a blowing-induced bronchoconstriction in an 11-year-old girl. And in the spirogram, you will see that the curves on the flow volume and volume time graphs follow the same shape, but they get smaller with each subsequent blow. So the numerical results of the FVC and the FEV1 get lower with each blow. You can see it particularly in this example on the volume time graph. Okay, and if you look at the results, you can see that the FEV1 starts off at 2.62 and decreases to 2.57, then 2.45, and then 2.27. So you can see that there's this progressive reduction in the FEV1. All right, let's have a look at blowing-induced bronchodilation. So some children can develop bronchodilation with blowing, as I said. And in this instance, you need to keep on blowing until that child's bronchodilation stabilizes. So if you look at figure 7.4, this is an example of blowing-induced bronchodilation. And on this example, you'll see that the curves on the flow volume and the volume time graphs, and again, you can see it particularly on the volume time graph, they follow the same shape, but they get larger with each subsequent blow. And the numerical results for the FVC and FEV1 get higher with each subsequent blow. So if you look at the FEV1 on this printout, the FEV1 goes from 2.18 to 2.25 to 2.28 to 2.32 liters. So as I said, it's very important that when you see blowing-induced bronchodilation, you keep that child blowing until that dilation has stabilized. All right, so once you've finished with the test itself, ask the child to remove the mouthpiece himself. So once the mouth has been on, you don't touch it again. The child simply pulls out, depending on which spirometry you're using, just pulls it out, throws it into the biohazardous waste, and then you give them some hand sanitizer or you send them to the basin to wash their hands. At that point, you are going to evaluate your test results and record and report on that test result, which again, we will go into detail in the next chapter on that. Just a quick word on data validation. So when we talk about the validity of the data, I will often say to somebody, is this data valid? And what they do is then try and interpret the test as either normal or obstructive or restrictive. That's not what we're asking when we talk about test validity. The validity of the test is purely about the quality of the blows, and if you have at least 3 blows that are very identical in that testing session, so that's acceptability and repeatability. So spirometry quality assurance includes examinations of the flow volume and volume time graphs, as well as the numerical values of the test for evidence of technical errors, because we don't want to be interpreting a test that has technical errors. So if you finished with the testing session, you want to look at that result for validity before that child leaves. Because once they've left, if you don't have quality blows, they're not going to be useful for interpretation. So technically poor spirometry may have little value or it can be misleading. So you need to be sure that those technical inaccuracies are noted and corrected. So this is data validation. So what we're looking for is at least 3 acceptable blows. That's blows which are perfect in every way. And at least 2 of those blows are repeatable, meaning that they're absolutely identical. You really need to be checking the acceptability and repeatability after every blow that the child does during the testing session, so that you can correct the child where they're going wrong. And you will get used to doing that as you go along. A test may be unlikely to be of any real clinical benefit to a compromised child. So that's children with any of the conditions that are listed in this table here. In some instances, with the correct support and patience, the technician may be able to achieve acceptable and repeatable test results. But in other instances, you're going to have to delay testing until the children is better. So let's look at a few of the problems that we have with compromised children, what the contraindications are, or what the issues are, and then how to manage these. So sometimes you'll have a child who has an inability to follow directions. Now, this could be because of confusion. The child might be too young. There might be language barriers. There might be communication problems, such as learning, disability, or mental retardation, or any other cause. So in this instance, the child will have a limited ability to comprehend and follow instruction. You would have to make sure that you schedule increased time for this child, that you exercise a lot of patience, that you coach them very, very carefully. You could use incentive graphics, and then you could request an interpreter. So maybe somebody who speaks the language of the child if you don't do that. You could also use a lot of non-verbal body language to try and interact with the child if there are language barriers. So yes, those are a few of the things you can do for a child who is battling to follow the directions. One of the other problems can be any pain of any kind. So either chest or abdominal pain, or even pain that's exacerbated by putting the mouthpiece into the mouth, oral or facial pain of any cause. So children who are in pain are not likely to blow forcefully, and that's going to compromise the test result. So the effort of blowing will also cause a worsening of the pain to the child, and we really want to try and avoid that. So some of the things you could do is support the painful area. You could, if necessary, reschedule the test for a later date. And very occasionally, if you need to use a soft mouthpiece, you can actually get silicone mouthpieces that are soft and pliable, which you could use for that child to blow with. You could also have a child who's battling with stress incontinence. If they have any particular condition, they could lose bladder control during the spirometric procedure. And in this instance, you want to offer suitable protection and reassurance. A child could also have nausea and vomiting and may be unable to conduct the test because of that. So you could administer an antiemetic medication, or you could delay the testing until the child is through the acute part of whatever it is and is manageable for spirometry. You don't want them to vomit into the mouthpiece. Let's have a look at the test quality grading table. So what we see with test quality grading is that there are 7 different grades of test that we can use to grade the quality, and that is grade A, B, C, D, E, U, or F. And the quality grade is determined by the number of acceptable tests that the child has blown, as well as the repeatability of that test. So in children who are 6 years old or younger, there are different criteria for children who are 6 years old and older. So when we're looking at repeatability, we're looking at the difference between the highest and the next highest FEC from acceptable blows and the highest and the next highest FEV1 from acceptable blows. So the repeatability grade is determined for the baseline maneuvers and then the post-bronchodilator maneuvers separately. The repeatability criteria are applied to the differences between the 2 largest FEC values and the 2 largest FEV1 values. A grade U indicates that only usable but not acceptable measurements were obtained. And the goal of the technician is to always try and achieve the best possible quality grade that they can when testing the child. The grading applies to the set of pre-bronchodilator maneuvers as a whole rather than the individual maneuver. So you see, you do all your blows, you get your 3 best tests, and then those are the ones that are graded when it comes to test quality grading. So quality grades A to C indicate a reliable test result and will be relied on for data analysis. And then quality grades D, E, U, or F indicates inadequate test quality grade, and those should be interpreted with extreme caution. So let's look at some of the critical factors when conducting spirometry testing over time. Okay, so what we need to do is standardize and document the testing protocol, the equipment used, and all the protocol and equipment that we have. So you need standard operating procedures so that everybody is doing the same thing every single time a person comes in to blow. Through that, obviously, technicians have to have had initial and periodic training, and then there must be the periodic audits so that any errors that a technician is making can be picked up and corrected. We need to maintain our equipment, preferably avoid any unnecessary changes in equipment, because you want to test your child on the same equipment each time they come so that you've got that consistency over time. And try not to make too many configuration changes on the spirometer. Rather set it up well in the first place and then keep it the same as you go along. You need to make sure that you have verified the spirometer accuracy. So you need evidence of the validation testing. So you need a baseline calibration, and then you need each of your calibration reports thereafter. You need to conduct the testing in the same posture. So as I said before, if the child sits, they always sit. If they stand when testing, then they always stand. You need to conduct testing at the same time of day and preferably in the same season, depending on if they're periodic tests. That is ideal, so that you don't have the time of day variability in lung function showing up on your spirometry, and you don't have the seasonal changes that a patient may have on spirometry wherever possible, obviously. So this brings us to the end of chapter 7. I'm going to go through a few quick did you knows. So did you know that even tests that have 3 acceptable maneuvers, of which at least 2 are repeatable, may not represent an individual's maximum effort? Ideally, you have to have at least 3 maximal effort curves of the same size and shape. Results from invalid tests must not be discarded, as there may be some useful information on the test that can still be used to assess that patient's respiratory health. Some medical conditions prevent an individual from successfully recording valid tests, and about 5% of the population really struggle to give you a good blow. So you will have some failure in your testing program, but hopefully not too much. The choice of bronchodilator when you're going to do a bronchodilator test is a clinical decision from the clinician, and we will deal with this in chapter 10. All right. So that brings us to the end of chapter 7, and we will shortly go on to chapter 8.